Welcome to Forward Physio, the show that gives you high-quality information about injury and rehabilitation, performance, and health. I am Noah Mandel, and I'm a physical therapist in Toronto, Canada. The purpose of this podcast is to give you educational content, not medical advice. So if you are dealing with a health-related concern, please take it up with your healthcare professional. If you enjoyed the podcast, I would really appreciate it if you'd be willing to leave a review. It takes 2 seconds, and you would be doing your part in helping the podcast grow so that we can provide this information to more and more people. Thank you very much for listening, and I hope you enjoy. Hey everyone, welcome back. Today I had the absolute pleasure of speaking with the very intelligent Dr. Nicholas Rolnick. Nick is a researcher, a physical therapist, and a personal trainer. His area of expertise is in blood flow restriction training, and if you haven't heard of that before, it's what it sounds like. There's actually a lot of good research behind it, and it has applications in a few different areas, and Nick will break them all down for you in today's podcast. At points, Nick goes pretty deep into some physiology, so bring out a pen and a notepad because it gets pretty in-depth. So without further ado, I bring to you my conversation with Dr. Nicholas Rolnick. All right, I am here with Nicholas Rolnick, and we are here to discuss a certain modality, blood flow restriction training. And in the world of physiotherapy in the past, modalities probably have gotten a bad rap with things like ultrasound. Maybe some people are against TENS units, but I think BFR, blood flow restriction, is one of the most fascinating and promising modalities that are available right now. So hoping that today we could get a whole background on this topic and give you guys a lot of knowledge and some ideas about how to apply this practically. But before that, Nick, do you mind just introducing yourself, telling us a little bit about you and where you are in the world and what do you do outside of the world of research and rehab?
Well, first and foremost, one of my colleagues, Kyle Kimbrell, would kill you if he heard you refer to BFR as a modality. I think we have discussed it being more of almost like an exercise technique or something that's applied commonly during exercise. Although I can see how people could assume or think of BFR as a modality. So that's a conversation in and of itself. But first, thank you for having me. I always enjoy speaking about blood flow restriction. It's refreshing to see the change in sentiment regarding this. For those that don't know anything about me, I, in short, am a physical therapist, personal trainer, and researcher interested in muscle hypertrophy, but more so a emphasis on blood flow restriction, and certainly in the weeds in BFR with regards to device features and characteristics, of which I'm spearheading some of the early research in this area. But I've always been interested in fitness ever since I was a teenager and was very fortunate enough to pick it up early. And BFR is just the natural extension of my love for muscle growth. I started to hear about it in my master's degree program, and I saw somebody in the gym wrapping themselves with a band and was a decently sized human. And I went up to him and I was like, "What are you doing?" And he was like, "This is called occlusion training, and it's going to give you a sick pump and increase your muscle size." So I was like, "Sold. Okay." And then I started to do that with powerlifting straps, and it was just cumbersome. I tried it for a couple of weeks and then I put it down. This is back in 2012, 2013. And forgot about it really until about my second year in PT school, where I saw an article. I came across Jeremy Lenecke's article on practical BFR, where you're using those straps and you're exercising, and it was published in the journal Strength and Conditioning Research. And I was like, wow, okay, um, there might be something to this. And then at that point in my life, I had a lot more knowledge on exercise from my doctoral studies at Columbia. And then I kind of just went full blown in. My type A personality, I was in ADD all throughout my youth. So, but if I found something that I was interested in, I dove right into it and I just loved it. And then I started posting on Instagram to keep myself accountable and to the research that I was reading, and I would get trolled like you wouldn't believe.
Mm,
Um,
mm,
People are like, "Why the hell would you do this? This is ridiculous! Like, just lift heavy," and all these other things that people would say to dissuade me against continuing my investigation into BFR, and kept on posting, and that caught the attention of one of the cuff brands that was launching a cuff, Smart Tools, and then I helped write their level 1 course, started teaching them for a little while, and then I decided, along with a couple of other people, that was like, hey, we don't actually just need to. BFR can be formed a number of different ways as long as we adhere to guidelines. Let's just start our own thing, and that was the birth of the BFR Pros. And so I teach with a number of different devices. I don't really have any allegiances to what cuff wins the proverbial race. I am more interested in helping this technology be as accessible as possible and reaching the people that need it the most. And for those that have no idea what BFR is, it is a technique that you are putting a cuff, more commonly an elastic or a rigid cuff that's pneumatic. So it's inflated with air on the proximal portion of your arm or your leg. And then you perform movements with it. Typically very similar movements as to what you would do in the gym or during your normal rehabilitation. And because of the unique characteristics of the BFR stimulus, that is, it reduces arterial inflow into the limb, restricts venous return, you're creating a relative hypoxic environment. And as such, it accelerates the fatiguing process. The same fatiguing process that occurs with lower loads, you can use with BFR and accelerate that process. And that's really cool because in the rehab population where they're load or pain compromised, typically we see both, that they can't lift the gold standard, 70+% of the 1 rep max. But if we lift too light, right, if we have a 10-15% of our 1 rep max, we can do that almost indefinitely. BFR allows us to reduce that time needed, and in order to get a physiological adaptation at lower loads or intensities. And that's really what it's about at the end of the day, is keeping people active, as my role as a physical therapist, to help them get back to the activities that they love as quickly as possible. And BFR just tends to be one of those modalities or exercise techniques that has been more effective than other approaches. And that's why I've really been passionate about its implementation and why I'm protective about its growth, and really passionate about separating the marketing from the science and understanding how to best apply it so it can help the most amount of people.
Awesome. That was an amazing breakdown and great introduction to the topic. So thank you. I think I first came across it just watching maybe a YouTube or Instagram video years back. And it was the same sort of thing. You see someone in the gym with that band on their arm. And the idea is that it occludes or partially restricts blood flow. And at the time, it sort of seemed crazy to me. And I sort of could get where people were originally coming from, sort of scoffing at you when you first started posting about it on Instagram. But as it sort of has panned out, there seems to be a lot of pretty strong evidence behind it. So I guess the idea, as you mentioned, is that it creates this hypoxic environment in the muscle. right? It fatigues things a little bit quicker. And then from there, does that mean, I guess, that it recruits the muscle fibers that typically wouldn't be recruited with light loads a little bit earlier on, and thus producing more of a muscle growth stimulus?
I mean, yeah, if we're simplifying it, what we do know about and how I teach and found the most effective in demystifying the process that is blood flow restriction in terms of the outcomes, particularly again with relevance to hypertrophy. And just as a side note, the reason why I found hypertrophy such a great entry point is because when there's hypertrophy that we can elicit, there tends to be a host of other physiological adaptations that happen, including vascular, right? We have increased capillarization, which can help improve aerobic capacity, which ultimately, with the additional muscle, can help improve muscle strength, and then ultimately feed into the muscle, the musculoskeletal system at large, which can then help with improving function, all things that are, as physical therapists, we care greatly about. And so when we think about conceptually, I think the easiest way, because we don't really know the true mechanisms. Now, we can always speculate, and my bias is that BFR operates exactly the same way as traditional strength training, even with respect to heavy load strength training in terms of muscle hypertrophy. Because we ultimately have to think, if there's all these potential mechanisms that get thrown around, like hormonal release, like metabolic release, like oxygen deficits or whatever, when we actually look at the literature, we can see that if we have equivocal sets to failure, so say we have 3 sets to failure and we're lifting at 70%, and then 3 sets of failure, we're lifting at 30%, and then we have 3 sets of failure that we're lifting at 30% with BFR, what we're going to find is it's the resultant hypertrophy is going to be the same. So my whole thought process is, well, okay, how can we explain a similar amount of muscle growth that happens with low intensity exercise and high intensity exercise, and with low intensity exercise with BFR to low intensity exercise alone? And I think that the majority of the mechanistic underpinnings that can connect all three is mechanical tension. And that just simply means that there is some, when the muscle fiber, because I think you have to zoom in to the muscle fiber itself, it just is reacting to the stimulus that it's around. And the body will ultimately figure out how best to move the body based on the stimulus. So even if it's heavy loads and light loads, at some point when we add fatigue, particularly with light loads, we slow the contraction speed down. But with heavy lifting, it's already slowed down because the weight's heavy. This goes back to the force velocity curve, particularly the concentric portion of the muscle shortening portion of the force velocity curve. So if ultimately we get to the same endpoint, then the mechanical tension explanation can explain a lot, if not all, of the rationale as to why we get similar growth between all different loading conditions. So with that being said, then, if we think about it, right, like the fatiguing processes are likely a little different between what happens as a heavy load and what happens with a light load. But at the end of the day, we care about outcomes, and the outcomes tend to be with low intensity BFR, with or without BFR, low intensity exercise with or without BFR. We tend to see similar levels of muscle growth, and the muscle strength, though, is less in the vast majority of, although we have evidence to suggest that strength may be equivocal, which again, hard to believe personally, just given how strength works. But that's another reason why you're not doing BFR for a long period of time, particularly like the resistance exercise stuff, if you can transition into heavy lifting, because heavy lifting is the gold standard from the neuromusculoskeletal perspective. So why would anybody stay with BFR for a long period of time if they can lift heavy. And I think that's the biggest knock that people kind of give is like, why are you doing BFR if you can lift heavy? And I agree. It's more painful. I mean, we did a meta-analysis on the topic of perceptual factors, which I'm very interested in, and showed that BFR can be more stressful or exert more discomfort than high intensity exercise. And when we do the same, if we just do low intensity versus low intensity BFR, when we're using non-failure exercise, tends to be more uncomfortable. So it's just like it all fits into this narrative that BFR is a bridge to higher intensity exercise, whether that's with aerobic or resistance exercise.
Mm-hmm. Yeah. And for those who have never tried it, those results there that you just discussed aren't too surprising. It is pretty uncomfortable and it's pretty intense. But I think what you just said serves into a good bridge into discussing using BFR in a rehab context. So as you said, it's not necessarily superior to heavy lifting, but in a rehab context, let's say someone perhaps just got a surgery or they're compromised in the amount of weight that they can lift. Is that when BFR is sort of the go-to in that sense? When you're trying to give someone a good, let's say, muscle building stimulus, or you at least want to get them to working out and going close to fatigue, but they can't lift heavy, is that sort of where BFR would come in, even in a rehab context?
Yeah, I mean, I think from a resistance exercise perspective, 90% of the use case of BFR is in those individuals where the alternative is not possible. And by the alternative, I mean heavy load strength training. Mm-hmm. And so what we need to appreciate is that following a surgery, there tends to be a rapid rise in anabolic resistance. And anabolic resistance is the decreased ability of our body to respond well to exercise or good nutrition. And we need a positive net protein balance to put on muscle, right? Become anabolic. And it's very challenging in the post-surgical case because we're not able to challenge the muscle. We're less active. All of these, along with, I'm assuming a lot of people are probably not eating as well as they normally would. You're creating this cascade that is feeding into this anabolic resistance. And what we're doing in rehab with very light loads, particularly in the early phases of post-surgical rehab, we're not really using any weights, if any at all. And therefore, we're not really able to, in most circumstances, truly challenge the muscle and drive that fatigue. BFR allows us to be able to do that. And we know that in contrast to heavy lifting, we know that in order to elicit a positive muscle building stimulus with light loads, we need to induce fatigue, because there's no way that we're going to be able to get that dose of stimulus. Now, I'm again of the bias that it's probably predominantly driven in exercise through the accumulation of mechanical tension with those type 2 muscle fibers, the ones that are more responsive to growth, the ones that are more on the higher are on to the right of the motor unit pool. So they're the ones that we can really only recruit when we're exerting ourselves in a significant capacity. When we're in the rehab setting and we can't really induce fatigue, we're never getting those muscle fibers recruited, and thus they tend to atrophy very quickly. And the thing that I have become way more appreciative of as I've been really diving into muscle physiology and metabolic physiology in particular is that muscle is a metabolic organ, and if it interacts with so many other tissue types. In fact, last night I was reading an article in bed. I was about to go to bed and I saw this just published article about the different ways in which aerobic and resistance exercise impact multiple tissue types and the chronology of that and what happens acutely and then what happens chronically. And it all feeds together. Everything feeds together in terms of optimizing health. And our society, at least in the United States, is very sedentary.
Mm-hmm.
And we need to continue to facilitate more active lifestyles in general. Following surgery, there's the narrative that, oh man, like, I need to rest and I need to get
Right,
ready.
right.
And it's not setting you up for a successful experience. And then it could further, you just take that down the road, and now it's creating a cascade, inducing more inactivity. And now you're type 2 diabetic, and that wrecks your system. Absolutely. So it's something that I'm very passionate about, which is, yeah, I'm a recreational bodybuilder. Like aesthetics are extremely important to me. As a personal trainer, aesthetics are important to me because my clients look to me to as an example. But it's really just so much more. And I think
Mm-hmm.
that the focus on hypertrophy allows me to diverge into, yeah, you look good naked, great, but also when you have more muscle, we're generally healthier.
Right.
And that is a really important part. And that carries into the post-surgical rehabilitation and why BFR could be such an effective um, adjunct therapy to what we're already doing in rehab.
Right. To sort of kickstart that process of building some muscle. Yeah, it's such an important topic, and it's a little bit of an aside, but I think just bodybuilding in general sometimes gets a bad rap from either, people that are into quote unquote functional exercise, or people that don't have a very strong knowledge of exercise because they look at it as something that's, purely for aesthetics. But as you said, people who generally have more muscle, and of course it's not so black and white, but it's generally true that they are a little bit healthier, or a lot healthier in some cases. So, it's definitely a good idea to have some muscle mass on your body.
Yeah, and just before we go on, I think it's really
Yeah,
important to also comment on the fact that social media doesn't really help. I think a lot of the fitness influencers that are out there try to make things more complex than they actually need to be. I think there is a need for programming complexity as we get more and more trained and our body becomes more and more adapted to a stimulus. I think at that point, it's really important that there are nuances. But I might be one of those people that where that nuance is really important because I'm very, I've been training for a long period of time. I'm, looking for the 1% gain over the course of, a year or two.
hmm,
But 99% of the people on
right.
social media just need to exercise, like get to the gym for 45 minutes, do some resistance exercise, and then go on a cardio bike or run or whatever for another 20 to 30 minutes, right? You don't need to be worrying about lengthened partials or how much volume you need to do to really squeeze out those gains because it doesn't matter. And I think social media is so fixated on how can we get engagement and how can we make a career out of like creating this complexity when it really is that simple. Get to the gym twice a week, full body routine, 2 to 3 sets per exercise, right? Then
Boom.
work and go on cardio 3 times a week, 30 to 40 minutes, right? It's not a game changing time commitment, but if everybody adopted that as part of their own lifestyle, our society would be completely transformed.
Mm.
Completely. Everything. And it's so frustrating when you're on Instagram when it's like none of the educational posts really do super well because people don't care about that. They just want quick engagement and they want quick stimulus and move on. And so I think it's just really important that we think back to the basics, and that's kind of where I lie with BFR as well. Like, we don't need to increase the complexity of our BFR interventions. We just do what we're normally doing in our rehab. We just add BFR. Even if you're changing or even if you're doing 3 sets of 15, right, with whatever exercise you're doing, just add BFR to it. You don't need to now go, oh, do I need to do a certain repetition protocol or whatever? If you understand that BFR will accelerate the fatiguing processes that are occurring normally in whatever exercise you're doing, right, you're already operating in a closer proximity to failure. That's going to be a greater relative hypertrophic stimulus to the muscle that you're giving, and thus you're going to get a greater benefit. You don't need to keep this with this complexity here. It's literally understanding principle-based and then understanding how that can potentially fit into, your everyday as a clinician.
Hey physios, I know that we all know how expensive continuing education courses can be. What if you had the chance to learn from some of the brightest minds in the industry from the comfort of your own home, all at the fraction of the cost of those weekend courses? This is where Masterclass by Physio Network comes in. Imagine having front row access to the world's leading experts breaking down complex topics into digestible module-based video courses. It's basically like Netflix for physios, and it gives you the option to learn about a ton of different topics. If you're interested in a particular area, the chances are the Physio Network already has a masterclass on it, or they're working on one right now. Masterclass is your ticket to staying relevant, informed, and delivering the best care possible to your patients. Click the link in the show notes and use the discount code NOAH10 at checkout to get an exclusive 10% off on Masterclass. Don't miss this opportunity to elevate your expertise. If you're still unsure, test it out with a 7-day free trial. You're going to love it. Right. Yeah, I couldn't have said it any better myself. It's just, I think a lot of the time we need to take a step back, look at the bigger picture, and as you said, realize that the vast majority of people are not exercising enough. And the nuances and the complexities don't really matter that much if you're not exercising in the first place. Speaking of, trying to help people be a little bit better off, we spoke about the post-surgical context a little bit, but let's go a little bit earlier in that sort of setting. And I guess this is sort of where I might think of BFR as modality sometimes, and I hope your colleague doesn't kill me, but it's when it is being applied passively. When someone is bedridden and you apply BFR to them when they're not moving. Could you sort of dive into that topic a little bit? Give us a background on why BFR might be used in that context and what the evidence says about that.
Yeah, I mean, admittedly, I don't particularly focus too much on passive applications because of my own biases towards getting people moving. I think that there's very little circumstances in outpatient physical therapy that I would say IPC or ischemic preconditioning would be something that I would do. Now, with that being said, IPC has its origins actually in the surgical literature, and they've been doing this for decades, right? And I'm no surgical historian here, but I know that they've understood that, at least in the context of reducing the impact of a hypoxic stimulus, meaning that if you had a stroke and all of a sudden you're hypoxic, then you have this tissue damage that happens. And that's because the body, or that tissue in particular, because it's usually a localized effect, at least at the tissue level, that tissue would be damaged, necrotic at some point, and then that's a huge issue. So they were looking at IPC, and they were saying, all right, well, in surgical cases, and I was on a radio show the other day where there's a vascular surgeon who is actually was introduced to blood flow restriction through ischemic preconditioning. Now, ischemic preconditioning, for those listening have no idea what I'm talking about, is very high amounts of pressure. So it's 100% of the pressure required to completely occlude your limb, typically a little bit higher because they want to buffer it, because the cardiovascular system will attempt to overcome the restrictive stimulus. And it's left on for 5 minutes, and then they deflate it, and then it's repeated 2 or 3 times, with a 3 to 5 minute rest in between. And what he was familiar with is they do this before vascular surgery, where they're replacing or operating on some tissue, and they are going to be in a no blood flow for 40, 50 minutes or whatever. And so what they would do is they would clamp an artery and they would release it, clamp it and release it. And the literature does show that there is something to that by giving a controlled bout of ischemia to induce a controlled injury to the tissue, that will enable the upregulation of cellular defense mechanisms to prevent the magnitude of ischemic damage that would happen after, afterward. And they've done this with great success in transplants. So they would create some ischemic protection in heart, in kidneys, in liver. All these different organs have been studied. They've also found that opioid use post-surgery in these cases have been reduced, or the magnitude of pain that they're experiencing has been less.
Wow.
This could all be attributed to this ischemic stimulus and the adaptation that happens. Because our body, at the end of the day, will recover if we give it a stimulus that is beyond its capacity, but not greatly exceeding, because then at that point you're really creating a stress you can't recover from. And so you circle back to the outpatient orthopedic physical therapist that, they come and they're concerned about the application of BFR to their client, even post-surgical client. And they're like, oh, wait, is anything going to happen, with this? And recognize that surgeons are doing this in a 40 to 50 plus minute bout with very high levels of pressure, using a narrow-ish cuff, sometimes not. I think it's moving more toward wider cuffs in surgery, but doing this mixed with medication and everything else, and they're fine. Now, granted, they're passive, they're not doing anything, right? But it's always good to have a framework for how you're viewing something. And I think a lot of the hesitancy has to do with a lack of knowledge, just a knowledge gap. And it's important to address that to help with fostering adoption of BFR. And remember that when we apply it, right, even when we're passively applying, number one, it takes a long time. So that's a barrier for use in general, like in the initial early stages. But typically I would perform some sort of like neuromuscular stim if it's early on, and not just super passive. But if I have somebody I'm like, I think that person might not like BFR initially, I'm going to put them passively, probably even lesser pressure than 100%, more towards 60 to 70% of that fully occlusive pressure, to see how they react. But IPC, because of this, there's trying to figure out what the mechanisms are that are responsible for the benefits. Because right now we've just talked about surgery and we talked about ischemic protection, but IPC has also been applied in the sports setting to allow for improvements in sport performance. And there's a lot of different theorized mechanisms as to why a passive bout of temporary occlusion and then reactive hyperemic response, which is how you have oxygen-starved muscle tissue that comes rushing back in, how that would lead to performance gains. And there's really cool literature on this. There's like a rabbit study that they actually took the blood of a rabbit that was undergoing ischemic preconditioning, and then they induced a heart attack on the other rabbit, and then they transfused the blood into the other rabbit, and then there was some degree of ischemic protection, suggesting that there's a humoral protective factor as well as a neural, which is again, like, for me as somebody that's looking to get people to exercise, and I don't work particularly much with elite sport, I tend to be more biased in terms of my interests and knowledge on resistance exercise and cardiovascular exercise than a passive approach. But that's kind of why you would kind of do it. There's also evidence to suggest that ischemic preconditioning can help modulate the pain response, and that is under investigation right now. I know at least one group is really looking into how much pressure to actually can provide a clinical benefit to that. But again, we also get that pain relief with low intensity exercise at BFR. So it's like, again, it goes back to like, maybe it's just I'm not interested in that area, but I feel like there's better fruit to eat in the BFR space than there is with the passive approach. Yeah. Although I do think there are some interesting concepts that more relate to elite sport than would to like the everyday patient in outpatient orthopedics.
Okay. So I think at this point we have a pretty good background into using BFR for vascular effects and for hypertrophic effects for muscle. You just touched on pain a little bit there. So it can have an analgesic or pain relieving effect, right? And I'm curious if that is different from just regular low intensity exercise, if it's better than that. And if it is, are there any potential mechanisms that might be the cause for that? And we know pain's complex, so I mean, we might be entering a rabbit hole here.
Yeah, I mean, listen, from how they're measuring, okay. So there's two different ways in the research that they've been measuring pain. They've been measuring actual reported pain from people that are in pain, right? So these are the post-surgical studies. This is like Luke Hughes' research on ACL has shown that pain following use of BFR has reduced over time. There's other research that has individuals showing a lesser reported pain levels compared to the same exercise performed without BFR or to heavy lifting, in the case of Luke Hughes' ACL literature. But that's the one thing. So we know that there is some sort of effect of the BFR stimulus with regards to reductions in pain in people that actually have pain. And then there's the second body of literature. These are in normal individuals with no pain. And what they do is they basically induce a stimulus, typically through something called an algometer. So basically they take a device and then they jam it into the skin, and they basically say, all right, when this is painful, let me know. And so they take it pre, and then they do a BFR or a low intensity exercise, and then they assess it post. And they can do it in the area that is exercising, the area that's not exercising. So on the opposite limb, they can do it in remote regions. Like Luke has also done work in this area as well with Stephen Patterson. These are big names in the BFR area, and have basically shown that we can get similar amounts of exercise-induced hypoalgesia is the clinical terminology, that is similar to heavy load strength training, that might be pressure dependent, meaning that the more pressure that we put on our limb, typically closer to 80% of the pressure needed to completely occlude the arterial flow, versus 40% tends to be the provide greater effects. And this has been shown in aerobic exercise as well. And there's also some systemic impact of that, meaning that, say we have pain in our mid back and we do a lower body exercise, we do a high intensity lower body exercise, or we do a low intensity exercise with BFR, we can probably see similar amounts of hypoalgesia or pain reduction following that. So in terms of the mechanisms, they're still very much undecided. I think in the literature that has been published thus far, there is some the magnitude of exercise-induced discomfort has a large impact on the amount of pain relief that is, or exercise-induced hypalgesia. So I don't even want to say pain relief, because these people did not have pain when they were doing the exercise. So it's hypalgesia. So just their pain sensitivity got less. So they're able to press in more with the algometer. But there is work into the endocannabinoid receptors. Like, again, though, for me as a clinician, I feel like I don't really care about that stuff. And that's just, to me, like, not an area. Like, I'm not a physiologist in the sense that I want to know exactly all the mechanisms that are undergoing pain relief. You even said it before, pain is extremely, extremely complex. What I care about as a clinician is, if I apply something to a person, can I expect to have a clinically meaningful reduction in pain or an improvement in pain sensitivity? I do believe, based on my experience as well in the clinic, that there is some conditioned pain modulation that's happening. So the more that you induce discomfort, the more you're going to get relief afterward. And we know that exercise-induced hypalgesia is modulated predominantly by two factors. This is without BFR. Intensity, so the higher you work out, the higher the intensity, the greater the exercise-induced hypalgesic response, and whether or not the exercise is carried out to volitional fatigue. So the intensity of your exercise, not the intensity of the load. Those are the two factors that are predominantly responsible for the magnitude of the change pre-post of exercise-induced hypalgesia. So with BFR, we're not using a high intensity in terms of load, but we are operating much, much, much closer to failure. And it also helps explain why in Luke's research with the leg press, that they were looking at 80% and 40% versus high intensity strength training, that the 80% tended to be similar to the high intensity exercise, but greater than the 40%, even though they all improved relative to low intensity exercise, is because we're operating closer to failure. And the 80% is inducing more fatigue and thus more discomfort. So you're getting this, whatever system is going on, it's impacting the resultant hypoalgesic response.
It's so fascinating. And it's similar to what you were discussing before when we were discussing hypertrophy, how the effects of BFR aren't necessarily magical. It's just potentially helping you get to the typical mechanism that causes muscle growth a little bit quicker. And it might be the same sort of thing there when it comes to pain. I've seen you on your Instagram stories a few times now on a bike, and you have BFR on your legs. And we haven't really spoken about cardiovascular or aerobic training too much with BFR. From my understanding, the idea there is that it could help give you, again, a muscle building stimulus while you're doing an activity that typically wouldn't give you a very strong muscle building stimulus. And I guess the first thing I'm asking there is that correct? And the second thing is, are there any benefits that you get from a cardiovascular standpoint, let's say at the same intensity and duration on the bike with BFR than you would get without it? Does that make sense?
Yeah. So so resistance exercise with BFR to me is boring. It's boring because I think, first of all, it's much more well studied than aerobic exercise. So that just in and of itself. So there's just way more out there. We know more. And ultimately, there's really, in my perspective, now some people would disagree with me. That's totally fine. There's really only one way to grow muscle, through mechanical tension, and we're leveraging BFR for that. But when we think about aerobic exercise, with or without BFR, and we're looking at improvements in our aerobic capacity, that's just a generic umbrella term for, all right, we have a greater capacity to deliver and extract oxygen. Great. But there's a lot of different ways in which a stimulus can then impact the way that we're extracting oxygen from the environment, that we're pumping oxygen from the lungs all the way into the working muscles, to then extracting that oxygen into the muscle cell. So the mitochondria now can be able to leverage that for aerobic respiration. And then we need to also then think about the capillary network that is delivering that oxygen and offloading that. So there's so many different ways in which the aerobic capacity can be impacted with or without BFR. And the cool thing with aerobic exercise, you mentioned, can we put on muscle mass with aerobic exercise? And I would say, in someone like me, no. Why? Because if we take the narrative, and this is why I relate everything back to mechanical tension, because mechanical tension can really form the fundamental basis for connecting the dots. And so if we are typical in exercise with BFR, we tend to use low intensities. And with low intensities with aerobic exercise, that's typically less than 40 to 50% of the VO2 max. Very, very, very low. So that's basically just walking on a treadmill 2 to 2.5 miles per hour for the vast, vast, vast majority of people. Now, what's happening there? Well, in deconditioned individuals, where the threshold for adaptation is so low, us just moving slow and contracting our muscles with the added stimulus of BFR, we're now operating closer to failure, or we're inducing greater fatigue than would be expected without BFR, and we're moving at slow contraction speeds. So ultimately that can elicit some additional mechanical tension that wouldn't necessarily be there if the BFR cuff was not on. So we tend to see that in the more deconditioned individuals and the older adults, that we can improve muscle mass. And Christoph Sentner in 2019 did a nice systematic review and meta-analysis on the topic, showing that just walking on the treadmill can improve muscle mass and strength in older adults.
Wow.
There is some evidence that looked at athletes walking on a treadmill with high frequencies, meaning multiple times a day, and they did show some variable responses. I discount that. I mean, that just doesn't make any sense to me. So if we relate that now, so we've said, all right, well, we now understand that if we need to in order to build muscle, we probably, doesn't mean always, but we probably need to be contracting our muscles at a slow movement speed with high amounts of effort, or higher than normal amounts of effort relative to baseline. Okay, so we understand that that's how muscle builds with aerobic exercise. Cool, done. That also can explain why we tend to see some what we call proximal hypertrophy, more so in the legs than the arms. Proximal hypertrophy just means that we tend to see that there's a little bit more growth in the muscles that are proximal to the cuff, like the glutes, for example. Just walking on a treadmill, how does that make sense? Well, if we're thinking that in closed chain we're looking to extend the knee, then all the muscles that are distal to the cuff extend the knee by proxy, by either extending the hip or by directly extending the knee in closed chain. So once those get relatively fatigued, guess what's not as fatigued? The glutes. So now we start to get more and more hip extension in closed chain, and thus we get more relative demand, more relative demand at low contraction speeds, and therefore it is some sort of a stimulus. Fine. So that's why it's important from a rehab setting where I would get somebody, instead of doing passive applications, I would get them walking or I get them cycling if possible, given their surgical precautions. Because that is not going to be as stressful to them as exercising with BFR. You can acclimate them to the stimulus and still do something that's better than what you probably are doing in your time without it. And then you get into the aerobic capacity side. So we understand that just like muscle, our aerobic capacity with sedentarism rapidly declines. And that's a problem, considering that will impede our ability to do day-to-day tasks, because now our heart rate relative to our maximum heart rate in doing everyday tasks gets spiked. So our job is to increase the ceiling so that same relative stimulus you have more room to grow. So that's why it's important from an aerobic capacity standpoint. Now, where does my intervention play a part? Well, I think we need to then understand how normal BFR exercise has been implemented. So it's normally implemented bilaterally in low intensity exercise, where you're exercising either in intervals or you're exercising in continuous bouts of exercise up to 15 to 20 minutes. Now, how does aerobic exercise with BFR impact arterio and angiogenesis? So the formation of new capillaries, or the formation of basically increasing the capillary network from existing capillaries. All of this is really important because it helps facilitate oxygen delivery, and then helps facilitate the onloading and offloading of oxygen and metabolites specifically, so we can then continue to operate at a higher relative intensity without accumulating fatigue. So normal exercise with blood flow restriction, we're bilateral application. We are maximizing a hypoxic stimulus because we're creating a blood pooling effect in the lower extremity and lower extremities typically. I mean, we can do upper extremity as well, but it's just not as common for a number of reasons, in my opinion. But we normally do cycling or walking. We get this blood pooling effect. We get these metabolites that tend to accumulate, although at a much less extent than resistance exercise. And then once we deflate, we now have the blood rushing back in. We have this shear stress that gets picked up at the capillaries, and that stimulates the release of nitric oxide, as well as vascular endothelial growth factor, as well as prostaglandins, other vasodilators that help with saying to the body, oh my gosh, I need to become better adapted to this stimulus. And over time, then that leads to this capillarization, this growth. That's what happens on the periphery. Not only that, we also have mitochondrial adaptations, because you have upregulations of PGC1 alpha, which is a main kind of I like to think of it as like a hub for both resistance exercise, but also aerobic exercise. Basically, it improves the mitochondria's ability to utilize oxygen, stimulates mitochondrial biogenesis, allowing for more mitochondria per unit area. Thus, we become more efficient at whatever we want to do. And in terms of that also is reflective in improvements in our aerobic capacity. Why? Because we have now more machinery to utilize oxygen. And as soon as we start to tip the balance between anaerobic glycolysis becomes a lot higher than what's happening in oxidative phosphorylation or utilizing oxygen, now we start to accumulate fatigue. Once we start to reach this critical threshold, typically called the critical power, then all of a sudden fatigue or lactate is kind of how it's measured, rapidly accumulates. At some point, we're going to fatigue very quickly. we want to bump that up as much as we possibly can. So we're utilizing oxygen a lot more. So all the adaptations around aerobic exercise are just that, helping us utilize oxygen more efficiently so we can bump that the anaerobic metabolism further and further down the road so we can operate more at a higher intensity. That's not even including the central adaptations when we're talking about low intensity, because now if you think about it, right, our heart rate doesn't really go up that much in low intensity exercise. And we did a meta-analysis comparing acute versus high intensity interval or high intensity exercise, and basically all the physiological things that we would care about: heart rate, lactate accumulation. Those are the two that really come to my mind in terms of the variables that I can remember from this. Are much less heart rate are much less than high intensity training. But the BFR had higher perceptual demands. It's more uncomfortable. So that's the cost of doing it. But we do know that over a training period, we tend to see slightly less, in my opinion, adaptations, but still significantly greater than the same exercise performed without BFR. If we're doing a work match, or we're doing 15-minute, intervals or whatever. So the reason why I give this extended background is because that all feeds into why I've kind of been really excited about the prospect of aerobic exercise inducing potentially greater effects on the cardiovascular system than if I was going to apply BFR with high intensity resistance exercise or high load resistance exercise. Because we know that we want to mitigate the fatigue response to maximize the benefits with heavier loads. So why would I want to decrease more of a good thing? So if I can do 8 reps with 80% or 75% of the 1 rep max, why would I want to do 6 reps? Like, what does fatiguing earlier get me? In fact, you just lost 2 potentially stimulating repetitions to help you grow and get stronger. Conversely, though, with cardiovascular exercise, there's a centrally mediated component as well. We get a little bit of the centrally mediated component with a low intensity exercise. Why? Because our heart rate gets elevated above what it would be without BFR. Or then over time, we get our stroke volume that then adapts. These are all centrally mediated adaptations that occur to enable oxygen delivery to get to the periphery. So we get extraction at the pulmonary system, pumping with the heart, and then we get the muscular peripheral type vascular adaptations that happen on the outside. So with that in mind, then you shift it to high intensity exercise, right, where we're working, at higher intensities of exercise. And I'm not going to put a number on it, but I mean, for me, I'm working, 145, 150 beats per minute. So, that on a quick calculator, for me, that would be 220 minus age. I'm 35, 185, 150 divided by 185. So I'm at about 80 to 81% of my heart rate max. So I'm exercising at a relatively high intensity. So we already know that that's the gold standard. We know that we're increasing central adaptations. We're going to increase peripheral adaptations. Fine. What I'm so excited about with this is I've been applying BFR and doing cycling on one leg only. And that reason is because I'm able to, when I'm cycling with just one cuff on, I'm able to maintain the intensity at a much higher pace than I would if I was applying it bilaterally. So my central stress is much higher. But because my central stress is much higher, it's going to maximize the peripheral stress. And then when I add the BFR cuff on that one leg, it's going to maximize that peripheral stress even more, because now I'm trapping this the blood flow in that exercising leg. So now I'm stimulating more of the oxygen starvation, basically, in that limb that's under restriction. But now I'm able to with technology that's been released with BFR, I'm able to effectively program in interval work. So another potent stimulus, which I talked about earlier, is shear stress, meaning that as the blood flow goes through and rushes in to the oxygen starved muscles, that it stimulates these endothelial cells in the very small diameter capillaries, and that allows for vasodilation. And that vasodilation is a stimulator for growth. And so with the interval work now, I'm able to operate at an even higher intensity than I could if I was continuous. But now I program a 5-minute interval followed by a 2-minute rest, where I'm able to then get the blood back into the exercising muscle. I get the shear stress from the reperfusion. I get the maximizing the hypoxic stimulus in that particular limb, and I'm operating at around 80% of my heart rate max. So I'm able to keep the intensity high, and I'm able to get the reperfusion in, and I'm able to accumulate volume. Mm-hmm. So that's another thing. Like, a lot of times people are using BFR to not accumulate volume. But what I'm using it for in my own training is I want to accumulate volume, but I want to accumulate that volume with blood flow restriction. And I'm able to do that because even with the cuff on, and I'm using a moderate pressure, like 60% of my arterial or limb occlusion pressure. So it's really on the lower side. And I think that's where the whole body of literature is actually going, is lesser pressure, more moderate version of that. Earlier, like 10 years ago, 5 to 10 years ago, is you thought you needed high pressures to be able to elicit this, but it's just not comfortable.
For aerobic exercise, right?
For anything, for resistance exercise, aerobic exercise in particular, it was like, 80%, but it's so uncomfortable. Like it's really not good. So this though, I can 100% see that if somebody is looking to really push the limit, and I'm not doing any experiments on myself, I'm only just, testing it out. And then I also have, I'm running as well. So I'm translating that, and I'm seeing, like, I'm able to run for longer at a less RPE. Again, I haven't had a max aerobic test. I'm actually having one this week to see kind of where my VO2 max is. But yeah, I mean, that excites me because I think that there is a space, and we've already been seeing this in the aerobic literature, that when you combine aerobic exercise with high intensity interval training, most, not all, but most studies have shown a benefit beyond just traditional high intensity exercise. And I think that's because you're maximizing the central and peripheral stress at a given unit of time.
Mm-hmm. Yeah. Okay. That answers that. Amazing breakdown. The amount of knowledge that you've been able to present in this hour has been incredible. I think it would be really good to just summarize with, I guess, practical applications. If people are interested in using BFR, which by now I hope you are, how do they do that? So let's talk hypertrophy. We know you put it proximal to the cuff. What are the pressures that you put on for the upper limb and for the lower limb? And I know it depends, but what's the range?
Yeah, well, first and foremost, if you're manipulating any sort of, vascular system, I would try to do my best to get trained by someone and use the equipment first. Like, while BFR is largely, if not, I mean, I personally, on a side note, I was at CSM last year, and I was listening to the BFR talk, one of the BFR talks, and they're using BFR in patients in the intensive care unit. These are patients that are mechanically ventilated, and they're having them do recumbent cycling. Okay, so the sickest of the sick are using BFR.
Wow.
Right now, note they're extensively monitored, whatever. So that's that. But you're still manipulating the vascular system, and thus, a podcast is not the best way to understand BFR. It's really getting experience in that. But with that, don't don't think too hard about it, right? If the goal of hypertrophy and low loads, and really even low loads for strength, we need to induce a fatiguing effect. We need to get the type 2 fibers stimulated. So typical recommendations are 4 sets, 30 reps in the first set, followed by 3 sets of 15. I don't personally think we need that many repetitions. I think 3 to 4 sets of 15 reps actually will get us very close in the ballpark. We are working through a systematic review and meta-analysis now that's in peer review that we have synthesized the evidence and really showed that we probably need less reps than that 75 in order to gain a benefit. But again, not published, so take it for what it's worth. But that's kind of been my bias. And look clinically for signs of fatigue, right? If you start to see the muscle shake because it's getting fatigue, everyone sees the quad shakes when they're doing, leg extensions. It's that same type of thing. If we're able to contract under slow movement speeds, regardless of the repetition range, we're going to induce a hypertrophic effect. Okay, so you can either take it for what it's worth, slap on cuffs. If you're already doing 3 sets of 15, great. Do 3 sets of 15 now, add the cuffs. 40 to 80% of the arterial occlusion pressure, I tend to stay 40 to 50% in the upper body and 50 to 60% in the lower body. But if I'm using an exercise that's basically no weight whatsoever, I'm going to go closer to 80% in the legs. I don't really do that much in the upper body, so that doesn't really matter. And then the same guidelines would be for aerobic exercise. Now, how many sessions would I do or exercises would I do in a workout? I would say no more than 2 or 3 per muscle group. If you're doing more than that, you're not doing BFR because it's not, listen, I do BFR pretty consistently, and to just get through 4 sets of bicep curls, I'm dying. So it's like you could do 2, maybe 3 exercises per muscle group, particularly if they're different ranges of motion. But yeah, any more than that, and I question if you're actually doing BFR. Mm-hmm. For aerobic exercise, whatever you want. I typically start out people with 2 to 3 minute intervals on the bike at a pace whatever they can keep up with. I don't even track what they do. I just know that, hey, it's going to be better than what they're currently doing. And then if they get more and more trained, I'll chain intervals together. So now instead of 2 minutes, it's 5 minutes. And then I'll keep them cycling though in that 1 to 2 minute period where they're off. So they're still getting blood flow, they're still doing it. And I have technology now that I can pump up while they're cycling, so I don't have to have them stop, and accumulate, 15 to 20 minutes of aerobic exercise. Typically in the clinic, obviously I'm doing more than that, but I have time for that. But you'll still get a therapeutic benefit with 15 to 20 minutes of BFR. And then, you can ultimately chain that into a major 15-minute to 20-minute session of continuous BFR to maximize the hypoxia within the exercising limb. And yeah, that's BFR simplified, really. Mm-hmm. There's not a lot of obviously you can get into a lot of the complexities with what cuff you're using, what are the different features, but those at the end of the day are potentially, they're interesting to me, and my research does show that they can have an impact, but for the everyday person that's looking to implement BFR, that's a good starting point.
Cool. I guess one thing that we didn't say explicitly, but might be clear by now, is we sort of started talking about BFR like it was, like a rubber band, and it can be that, but obviously we're talking about percentages of occlusion. So yeah, these are electronic devices for the most part. And I'm glad you mentioned that 30, 15, 15, 15 rep range, because I was going to ask you about that. I'm of the same bias that when it comes to hypertrophy, it's more so about mechanical tension and, how close you're going to muscle failure. And I figure there's more than, 1 rep range that could work. If we're seeing that in the rest of the literature when it comes to muscle growth, whether it's 6 reps, 15 reps, or 20, I would think it's the same with when you apply the BFR too, right?
The reason why, in my opinion, that the 30, 15, 15, 15 has been adopted is because, number one, they showed it worked. Mm-hmm. Number two, Number two, it allows for comparisons between studies. And that is the most important thing, is that when you look at the body of research in strength training, you get a very large heterogeneity in subjects, in protocols, not even including the resistance training prescription. And now with the BFR literature, you have all three of these. And now you add, not only you're adding the BFR prescription, but also the cuff and what the cuff is, the features that the cuff has, all of which can have an impact on the outcomes. And that's kind of where my interest is in terms of shepherding the growth of BFR, is that I want to try to create as much homogeneity as possible in the literature base, which is why I'm very much a proponent of personalizing the pressure. And while I understand that other cuffs that don't have the capacity to personalize the pressure probably work, much like light exercise or low intensity exercise to failure works, right? I'm looking for optimal, and I'm looking for a way that I can compare study results. Like, obviously anything you do in the clinic, if you have them exercise to failure, you're giving them a potent hypertrophic stimulus. But if I don't have to do that, and I know that a study said, hey, I can use this repetition range and be okay, then I'd much prefer that. I think where my concern is that because cuffs have the potential to induce different physiologic adaptations, given that there are multiple cuffs that are coming out on the market that are not purely straight up tourniquets, meaning that they fully encompass the limb, that is sort of my concern more or less than the efficacy perspective of doing that. But yeah, those are just things to keep in mind when you're implementing BFR. None of that really matters if you're going to get somebody, you're going to do one session and you might do, let's just say 3 sets of 15 repetitions. Okay, if you've done it once and they tolerated it, okay, well then maybe you do 3 sets, but 15, and then get them to failure. Mm-hmm. Right? So that the application of BFR is going to accelerate that process. And we already know from the strength training literature that if you reach failure, your myops, or your myofibrillar protein synthesis levels, increases 100%. And we also know that if you increase the amount of sets, you probably need to do 6 sets total to be able to double myofibrillar protein synthesis, meaning that it's a diminishing return as you get more and more sets. So really, for us in the clinical perspective, it's really important to get to failure or very, very, very close to failure for at least 1 set. Mm-hmm. So we know we're significantly stimulating the anabolic processes to help that person combat anabolic resistance.
Got it. I have one last question for, being in the clinic and working with someone. I personally, and this is a question just I've come across myself, just based off of using the cuff with people. We have a unit in our clinic, and we see a lot of post-surgical cases. So a lot of people, it makes sense to use BFR with them. And I see some people one time a week. And I was hoping to ask you, is there a minimum effective dose here with BFR? Because we're using it to help them sort of get to this muscle fatigue point. But if they struggle to get that without the BFR unit, and I'm seeing them once a week, is it worth doing it still 1 time a week, or do they need to do it more? I think it might be a tough question to answer, but what do you think?
Yeah, I mean, I have a similar model in the sense that I tend to see patients 1 to 2 times a week at most. Typically, if I'm only seeing a patient once a week, I tell them, listen, this is not going to be optimal. Mm-hmm. This is not going to be the best case scenario. So typically, they either buy cuffs themselves, which the patients can buy cuffs these days. It's not that difficult. And then we program outside of the clinic so they're able to get 1 to 2 more exposures to the stimulus, or we just don't do BFR. Again, it really is up to the person to make that decision whether or not they want to commit or not. Sometimes I have cuffs that I can rent them, but again, the minimum dose, much like I don't actually know if there's been studies that have used BFR once a week. I think the minimum frequency that I've seen is twice a week. I may be wrong, but it operates similar to regular strength training.
Mm-hmm.
So like I would imagine that twice a week, a couple of sets close to fatigue is going to give you, the vast majority of those benefits. But that would actually be an interesting area to kind of look at. My bias is like, listen, if this is important to you, if your rehab is important to you, you either make the commitment to come twice a week for 6 weeks, so we know that at least you're getting past that hump, or you make the commitment to buy cuffs or rent cuffs yourself, and we basically cover one session cost so I can monitor you remotely, for example. Those are the things that I've done to present to clients as to what they want to do.
Awesome. I think that's a great answer. Cool. Somehow we covered everything I wanted to discuss, and I credit it to you. I think you're very, very organized in how you delivered everything, and I appreciate that. I think at the start of this podcast, I'm going to have to warn everyone to sort of get a pen and paper out so that they could take some notes, because I think you just, delivered a really, really good masterclass here. If people want to learn more, either about you, the work that you've done, or about BFR in general, can you point them anywhere?
Yeah, I have a website, bfrtraining.com. I also own bloodflowrestriction.com, so I literally own blood flow restriction. But we still are trying to figure out what we want to do with that. bfrtraining.com is our online courses that kind of take you through the thought process that I have delivered here today. My Instagram, the HPM, the Human Performance Mechanic is the initial, so the HPM. And if you're interested in more BFR specific content, the BFR Pros is my education company. You can follow any of those, and my clinic website, thehpmny.com, thehpmny.com. But yeah, just send me a DM if you have any questions. If you listen to this podcast and you're like, hey, I want to, buy your course, just DM me. I'll give you a discount code so you can get the course for a little cheaper. Be happy to do that.
Awesome. Cool. And you also are working on creating a podcast as well, right?
Yes, I have a podcast, the BFR Better for Results podcast. BFR stands for Better for Results, but it can also stand for BFR. And it's kind of a play on words because BFR is better for results. And that's an area that I'm obviously very interested in. But there are other techniques, other approaches that also, can be better for results. And that's kind of where that podcast is is definitely more in depth in terms of discussion than surface level. But yeah, thanks for allowing me to plug that.
Of course, yeah.
But yeah, this should be out in mid-January, depending on when this is listened to. So you should check it out on all available platforms that you listen to podcasts on.
Awesome. Cool. Nick, thank you once again. That was amazing. Really, really appreciate it. And it was a pleasure speaking to you.
Thank you. Yeah, appreciate the time. And hopefully the listeners got some useful information out of this. All my blabbering.
I'm sure they did. Thank you once again for listening to the podcast. If you enjoyed it, please consider leaving a review. If you would like to follow me on social media, you can follow me at noahmandel.physio on Instagram and TikTok. Have a wonderful day, and remember to keep moving forward.